I don't have any disclosure, and I'm presenting a case of 52-year-old male who was having hypertension for 10 years and well-controlled diabetes mellitus for 5 years. In past, he had history of transient ischemic attack, but lately for 1 year he was off treatment by himself. So in the night after his dinner, after having his evening walk, he had stretching pain in left forearm, later on involved left shoulder. Then there was heaviness in right side of the chest, which became diffuse, and later it was radiating to neck as well as angle of jaw. His ECG was performed, and we can appreciate that there was ST depression in 1 ABL and V5, V6. There was slight ST elevation in lead 3. Echocardiogram revealed concentric LVH with RWMA involving the inferoseptal, inferior and inferior segments. So the angiography was planned in the patient through right distal transradial access, that is through the anatomical snuff box with the help of Tiger catheter angiogram was done. We can appreciate that left main is normal, LCX OM is okay, the proximal LAD is having haziness, and we can see that either it is all thrombotic lesion, but the patient was not having any history past ACS or CCS, or it may be a dissection, non-flow limiting dissection but differential flow. In RCA, it was anomalous in origin, it was totally occluded, it was retrograde filling from the LAD, and the PLVB was filling, the flow was converging into proximal PL branch both from PDA as well as from the collaterals directly. Also we can appreciate that the conus branch is giving flow to the LAD. So at this moment in this patient with anomalous RCA, difficult course, RC being the culprit lesion, however it appeared to be acute on chronic being good collaterals, and not only the collaterals to RC, it was also giving collateral to LAD. LAD looks me to be a recanalized vessel. There was good probability that we might not succeed with antegrade approach. Then what? Can we go retrograde also? And if we go with retrograde with this vessel with this much stenosis, whether the hemodynamics will be affected or not. And above this was that patient and family were not willing for CABG. So I opted for the hybrid approach through the right distal transfemoral axis with the help of 7 French MPA and later on AL guide. RCA was engaged, and on left initially I took the Tiger just for the contralateral injection. So with the help of Corsair microcatheter, wire escalation was performed, and finally pilot 200 did cross. It appeared as if I am crossing the proximal lesion. Still more crossing was attempted, and what do I see is that the vessel is not in the lumen, it is not, wire is even not near the lumen. Whether it is in a branch or it is extravascular, I really can't say, but the microcatheter couldn't be slid over it. So even the parallel wire technique couldn't be performed, wire couldn't cross the lesion parallel to pilot 200. So now I opted for the contralateral, and 6 French guide XB3. The Sion black wire was advanced, is easily crossed the proximal LAD lesion, and over it the caravel also smoothly slid. The first septal was not planned for the crossing, rather I entered through the second septal. Contrast guided surfing was performed, but it couldn't be successful. So I entered through the third septal, and under contrast guidance the Sion black wire crossed the collateral through the PDA into the mid RC. However, the caravel was not crossing the collateral. At this moment, keeping the collateral where it is stopped with gentle maneuvers, the Sion black wire was advanced and it did cross the lesion completely. Now, in the curved segment of the RCA, I tried my best to enter the wire into the antegrade Corsair catheter. However, it was not going. Constant and gentle manipulation lead to the entry of this retrograde wire into the antegrade guide. And now in the curved segment of the guide, it intubated the antegrade Corsair microcatheter. And now gently and constant efforts in the form of tip-in technique in the Corsair crossed the lesion. The Sion black was withdrawn gently and it was advanced into the distal LAD as we very smoothly entered through the proximal LAD lesion. While these Caravel microcatheter was kept in proximal LAD and guide was disengaged. The antegrade microcatheter was wired with the help of a run-through, but there was some difficulty while it was coursing into the proximal PLVB and the guide was greatly backed. Anyway, Sion Black entered into the PLVB branch. Sequential predilatation could be performed with the help of body wire only, and after predilatation this was the angiogram. So a long and high diameter stent was deployed. It was post dilated, and after post dilatation IVUS was performed. What I can see is that there was under expansion, the well apposition into the distal part of the stent. It was further post dilated at high pressure, and final angiogram as well as IVUS assessment was happy to me. Now, what do I see? That there is haziness in the PLVB region. This was the region where I had difficulty in passing the run-through wire as well. So I thought that there may be embolization of the thrombus and with some possible atherosclerotic plaque, but thrombosuction catheter couldn't cross, nor I could retrieve any thrombus. So I performed the IVUS could slid. That was good thing. And what do I see is that there is thrombotic plaque as well as thrombus. It is very well delineated. It looks me that possibly it is the embolized thrombus. So first I did the POBA, classical POBA, check angiogram. It looks that there is a smooth narrowing at the distal end of the dilatation segment. There might be IMH. So to look or rule out intramural hematoma, I again performed the IVUS, but luckily there was no hematoma. So we can appreciate that this thrombus is redistributed. It has now much more flat, but still there is significant lesion. And the landing zone is far proximal into the PLVB. A stent was deployed, it was post-dilated, and finally port was done as per the measurements we obtained with the IVUS. And this is the good result. Now, I did the assessment of the LAD lesion, and as we are coming from the second diagonal proximally, we can see there is plaque, and then there are channels, micro channels, and it is classical honeycomb-like appearance, though it is well seen in the OCT. We can see that the minimal luminal area is too low, and the origin of first septal is also affected by this disease process. In this longitudinal view, we can appreciate there are multiple channels. These are suggestive of recannulation of all thrombotic lesion, and the MLA was 2.3 millimeters square. I tried my best to cross the septal, but I couldn't wire it. Then I did a sequential predilatation, and again I put efforts to cross it, but I really couldn't enter into the septal. Then I put a long stent. It was very well post-dilated, and this is the final angiogram. I couldn't save the first septal, but I know that it was very well fleeing from the conus branches, and now even RC is also there to fill it. So I will say that there were many worst enemies in the primary PCI. In the given case, I would like to rename them. That there was anomalous RCA, the donor vessel was significantly diseased. With the help of Caravel, pilot 200 did cross the lesion, but I don't know whether it was in a branch or not. But the final angiogram tells that it was not in a branch there. Luckily, I didn't have any pericardial effusion in the case. Then the contralateral surfing was done, but Caravel got stuck. Finally, with great efforts, I could, the tip-in technique saved the day. Predilatation could be performed with the help of body wire only. And the stent was under expanded. There was disease in the PLVB. It was very well, the anatomy was very well made out by the IVUS, as well as the optimization of the stent which was placed here. Then the IVUS helped in the assessment of the LAD lesion. Crossing was in the first septal was not possible. Even after dilatation, it could not be crossed. Finally, the stenting was done, and good angiographic as well as intravascular outcome was obtained in the given case. The case has many take-home findings, but I would like to say that good collaterals are warning sign for the acute on chronic lesion, as in this case in RC, and a good planning with plan A and B and C is mandatory. If the proximal donor vessel is having a disease segment, then usually we go for revascularization of this segment before going retrograde. But there were many concerns, so first I tried to revascularize the RC. And low threshold and rapid interchange among various possible techniques is must to complete the procedure in a timely fashion without complication. And definitely the IVS not only helped in deciphering the lesion and also the optimization of the outcome. Thank you.